Good morning, everyone from Indiana, and good evening, people from Thailand and in the Southeast Asian country. So welcome back to the Learning with Indiana University season 2. And this is the last episode of this season that we are going to talking about the pediatric hearing loss. What is the clinical aspect and imaging findings. So today we have like two great educators together. So first one is Dr. Charles Yates from the otology and head and neck surgery. He is a division chief and he also involved in the medical education, and he also received 2 IU Trustee Award, 2 times for the IU Trustee Award. So he is one of the best educator that we have here. And we also have Dr. Isaac Wu from radiology that also received the trustee award from IU too. So this is like a 2 great educator that we have together today to give us on the clinical aspect and also imaging finding for the pediatric hearing loss. So welcome, Dr. Yates. This is your stage now.
Thank you very much. I really appreciate the opportunity to be here, and I think this is just an amazing program that you guys are putting together here, and a great opportunity to both teach and learn. So I'm going to go ahead and share my lecture here. Hope everybody can see my lecture there. Yes. So talking with pediatric hearing loss and really covering the clinical aspect of things, it's amazing when I'm doing a presentation how much radiology I have to take out, because my practice and your practice are very, very intertwined. There's so many things that that are related to the ear that we just can't see on our clinical physical exam, and how amazing the technology and the interpretation of my colleagues in neuroradiology and pediatric neuroradiology is for helping us take care of these kids. So I wanted to try to give a good taste of what our approach is to looking at everybody. I don't have any conflicts of interest to disclose, so we're really just going to go through and kind of talk about our epidemiology and the presentation, and even our workup of pediatric hearing loss across the board. From the very simple standpoint of the anatomy for otolaryngologists as a whole, and for audiologists as well, we look at the outer ear and the middle ear together, where these are the conducting apparatus of having sound get down to the inner ear. And then if you have problems with this conducting apparatus, that's a conductive hearing loss. The inner ear and then the auditory nerve really are where then the signal transduction of that mechanical motion of conduction turns into a nerve signal and allows us to interpret sound. So that's going to be a problem in that area, is a sensory neural hearing loss. So when we have conductive hearing loss causes, the most common thing we might see is a cerumen impaction, which is something that we can pick up on exam, and that can be cleared in the office. And that's not really the scope of this lecture, because we're not getting imaging in those situations. Middle ear fluid is the second most common type of conductive hearing loss, and that might result in a tube. And in most cases, we're not getting imaging on that. But then you have the more complex kind of longer term problems, such as a tympanic membrane perforation, cholesteatoma, otosclerosis, problems with movement of the osticular chain, or even lack of an ear. And then congenital hearing losses, that's when we're relying much, much more on our imaging for our diagnosis. Sensory neural hearing losses, the 2 most common things we see less in kids, noise-induced hearing losses, are unfortunately becoming more common, but meningitis and then the very complicated genetics of hearing loss we'll certainly touch on. Vestibular schwannoma and Meniere's disease occur a little less frequently in the pediatric population, but we'll touch on that just a little bit. So for any new patient we might see in the clinic or in a NICU or in the hospital situation, we're relying on hearing testing to help quantify the level of any kind of hearing loss that we do. And that depends on the age and developmental age of a child or an adult for us to be able to quantify that level of hearing. And then what we can get from the history and physical exam. So the most basic way that we do any type of interpretation of the hearing is with the audiogram here, which we can see the right ear here at the top is in the gray or normal hearing area for the most part until you get to higher frequencies. And with the audiogram, you can determine if, you conduct through bone, which is this, the little greater than sign, or pardon me, less than sign at the circle, there's no air bone gap. So when you have a hearing loss, this is sensorineural. We can see in this left ear that this is also sensorineural, and there's some other testing we can do. We can move the eardrum with pressure, that's impedance tympanometry, and in someone who's developmentally appropriate for speech, we can see how clear sound is for them. You see in this patient, in the right ear, they get 100% of words correct. In the left ear, they have a reduction in that word clarity score, and that can have an impact on your overall hearing. In the pediatric population, though, we're not always of the appropriate age to hear a sound and then kind of raise your hand and say, oh, I can hear this. So we have some other objective hearing evaluations where you can, in particular, do brainstem auditory evoked potential or auditory brainstem response testing. And this is clinically what we use for both newborn screening. So in the United States, every child is born is screened for a hearing loss, and kids who don't pass the screen get a diagnostic evaluation with an ABR. And this is kind of the most common test that we use before it's developmentally appropriate to be in a sound booth and at least be able to turn your head. Otoacoustic emissions are a secondary kind of objective measure that we use. So your outer hair cells actually produce a low intensity sound that can be picked up by a microphone. And if you deliver a sound stimulus, you can receive a sound stimulus back from this. And we can use this as another screen for detecting the health of the inner ear itself. Because it doesn't involve directly the nerves, it's not as good of a screening test as an ABR, but it's a useful test, especially if we're looking at maybe cochlear damage due to some ototoxic medications. So here's some examples that we're seeing of conductive hearing losses. So this is a tympanic membrane perforation in the left ear. We can see that we've got a greater than 50% of the eardrum is gone. We can see that there's no other disease process such as active infection or cholesteatoma going here, but we can see that there's a absent connection of the incus to the stapes, and erosions can occur in these situations. So with tympanic membrane perforations, you have less efficient conduction of sound to your middle ear. Now, for the most part, nearly 80% of these will heal spontaneously, but there are predictors of persistent perforation, older patient age of greater than 30, although, we see plenty in kids, and larger perforations and central perforations in the lower part tend to be associated with something that's more likely to need ongoing treatment, either of the hearing loss with a hearing aid or surgery to repair the tympanic membrane perforation. So sometimes more complex than the tympanic membrane perforation, which, depending on the level of hearing and the amount of recurrent infection associated with it, we may or may not get routine imaging associated with that. But with a cholesteatoma, this is something where we use imaging very, very consistently for diagnosis and for treatment. So cholesteatoma is basically skin trapped within the middle ear mastoid spaces, although it can be in the external auditory canal and other areas as well. And basically you have a keratinized stratified epithelial layer that's growing because it's trapped there. And this layer that kind of is where the keratin is coming from, we call the matrix, which is just a fibrous subepithelial layer. And this keeps making desquamated squamous cells that occur into a sac in the area. The keratin accumulates. As this sac accumulates, this can erode the surrounding bone. That can erode it from pressure, from recurrent infection, because keratin is full of protein, and this is at 37 degrees centigrade, in a wonderful place to set up a recurrent and chronic infection. So sometimes you see chronic drainage from an ear along with hearing loss when you have a presentation of a cholesteatoma. There are different kinds of cholesteatoma. Acquired cholesteatomas occur with kind of migration over time occurring into the middle ear space. And these are far more common than congenital cholesteatomas. Less than 1 out of between 20 and 40, depending on the study, of cholesteatomas are congenital cholesteatomas. And one of the ways we would diagnose a congenital cholesteatoma would usually be behind an intact tympanic membrane. Acquired cholesteatomas most commonly come from a retraction of the tympanic membrane in the top part, the pars flaccida, or posterior superior mesotympanum. And they usually occur slowly and may not be discovered until causing hearing loss or drainage, because sometimes this may be something that's trapped under a shelf within and obscured from the physical exam. And this is a place where imaging can help us to diagnose these early. Usually they can be seen on microscopic exam in the office. The discharge can be foul smelling, and you can also have bleeding associated with it. And there may be slight earache or headache associated with it, even some sense of dizziness depending on the location of the cholesteatoma. So here's a clinical photomicrograph of an acquired cholesteatoma. This is showing our essentially normal tympanic membrane, but here we see within the attic there's an accumulation of debris, but an obvious erosion of bone. So this is a something where just on the physical exam we would know that this is cholesteatoma. Sometimes that cholesteatoma might be associated with recurrent or ongoing infection. So here we see a lot more inflammatory process. We can see where a retraction pocket where the tympanic membrane used to be, and here superiorly, there are areas where you obviously have some bone erosion, you have some accumulation of keratin at the edge, but this may be only part of the picture. There are multiple theories that go around the etiology of this tumor formation, but these mechanisms really remain theories. They haven't been established as absolute unfettered truth. So secondary acquired cholesteatomas can occur from growth of the squamous epithelium through a tympanic membrane perforation. These occur usually when you have a perforation at the margin that involves the annulus rather than a perforation centrally. We can see primary cholesteatoma in the attic, where it develops kind of with a suction back process and accumulates. And this is associated with hearing loss when it erodes the heads of the ossicles due to enzymatic action and not as directly due to pressure necrosis. With within our scope of practice, there's no curative treatment for cholesteatoma other than to do surgery. So this is a surgical disease. We may use antibiotics to try to decrease inflammation and granulation prior to surgery, but they would be symptomatic relief rather than curative. And then the goal of surgery is then to get a safe, dry ear and then preserve or even improve hearing with subsequent reconstructions. And here's kind of the what we're looking at with our tympanic membrane. This is showing if we have, there's all this area in the mastoid behind what we can see on exam that we can only pick up with imaging from our colleagues in radiology. Superiorly, this is posterior epitympanum showing the pathway where we can have a cholesteatoma back in the mastoid. The surgical options that we perform, and you invite a surgeon to talk, you can always get more than more surgical discussion than you really want. So I tried to limit that for you guys. But we do make decisions about canal wall up versus canal wall down, and that is the canal that we're referring to as the external auditory canal and its presence there. About 95% of the time, that decision for me is made by the amount of erosion of the canal wall. I always prefer, if I can, to leave the canal wall up. The canal wall up, these advantages of leaving that external auditory canal intact is you have a more physiologic position of the tympanic membrane, so you have a higher possibility of being able to reconstruct more near normal hearing. You have a good middle ear space, and you don't have a mastoid cavity. A mastoid cavity isn't necessarily self-cleaning. So if you do a surgery with the canal wall down, that person the rest of their lives is going to have their ear cleaned out at least yearly. Disadvantages is you can't see everything as well if you have the external auditory canal in the way, so there can be hidden or even recurrent cholesteatoma, and often a second stage is needed to get, once you heal that tympanic membrane and get it at a physiologic position, that's going to be a very good prognostic indicator of a good outcome for hearing. Canal wall down, the advantages are residual cholesteatoma is easily seen and treated, and recurrence of cholesteatoma is a little more unlikely. But we talked about the mastoid cavity issues, and then because that middle ear is shallow, the hearing results aren't quite as good. So this is just an illustration showing a patient kind of in the surgical position. This is the canal wall I'm talking about. This is an intact canal wall mastoidectomy. But when we do the surgical mastoidectomies, and plenty of imaging is done in people who have symptoms after surgery, this allows you to see kind of what we do as far as a mastoidectomy. We saucerize the edges until we're seeing here the tegmen mastoideum, which is the floor of the middle cranial fossa. We skeletonize the sigmoid sinus. A lot of the time, we're actually going to take out the mastoid tip down to the digastric ridge here. And the facial nerve, we may open a facial recess, but leave, obviously, the semicircular canals intact. So another cause of both conductive and sensorineural hearing loss, and as well as, when you have both conductive and sensorineural hearing losses together, that's a mixed hearing loss that we see in children, is temporal bone trauma. Now, temporal bone fractures are a little more uncommon in children, basically due to flexibility of the skull bones. Unfortunately, that doesn't mean that we don't see them. It just means that with similar injuries, someone in the younger pediatric population is a little less likely to have the temporal bone fracture. Part of this is also related to having less aeration of the mastoid in youngest children, but there's kind of a bimodal distribution of when we do see that, with falls and the other activities of toddlers around 2 to 3 years. And then by the time you're involved in motor vehicles at age 15 and above. So we also sometimes, unfortunately, have to be concerned that temporal bone fractures in young children can be associated with non-accidental trauma or child abuse. The different classes of things we see here that can cause hearing loss in a temporal bone trauma without a fracture are concussive or barotrauma injuries, so significant pressure changes that involve the inner ear, thermal damage and compression, and then there's also penetrating temporal bone trauma as well as blunt temporal bone trauma, which has a number of different classification schemes radiographically. So congenital hearing impairment is a huge subject that I will admit to, in preparing any kind of presentation where I'm going to talk for an hour, there are plenty of things that I am glossing over. So for those things, I apologize, but I wanted to give you kind of a scope of our practice. Hearing impairment is the most common sensory deficit in the U.S. and in the U.S. it affects 2 to 3 per thousand live births, and that's 28 million Americans. As many as 5% of children have a hearing loss by 18 years in age, which the incidence then in the older population reaches 40 to 50% by age 75. So hearing loss is a significant has a significant impact in our society across the board. So one thing that you can identify just visually at birth is a microtia, so lack of development of the external ear or the pinna, or an aural atresia. The atresia is the lack of development of a external auditory canal, and these are mostly conductive hearing losses. And an aural atresia can be associated, like our picture here, with a pinna that's mostly normal in appearance. Microtias can have different amounts of ear that has developed, and this can be graded. This is a grade 2 microtia. More severe microtias or an anotia, a complete absence of the ear, may and often indicates more severe malformation of the middle ear. And microtias and atresias can be unilateral or bilateral, and they can be associated with some syndromes, but they don't have to be. Here's a example of essentially an anotia. So when we talk about other forms of hearing loss that are diagnosed congenitally, especially when they are sensory neural, we should mention the cochlear implant. The cochlear implant is considered when you have a hearing loss that cannot respond to a hearing aid. So a cochlear implant, when we're working up a child or an adult for that cochlear implant, we're never attempting or trying to say, well, this is better than what we are all communicating with here today. What you're trying to do is give a good representation of speech sounds, and it has some different parts that are external. You can have a microphone and a speech processor within it, and there's a transmitter that sends both the information and energy to an internal receiver stimulator, and then the electrode array within the cochlea itself. One thing that you can get from your implantation is improved sensitivity to speech and improved speech understanding, and you can use with a hearing aid on the better ear, and our surgical technology has even improved to where you can use it with a hearing aid on the same ear when that's appropriate. You can perform bilateral implantation, and then this is important with hearing losses if a family goal is to develop auditory oral language, and this acquisition needs to occur during critical developmental periods. One reason to talk about any type of cochlear implantation, just as a discussion with any type of neuroradiology lecture, is that every person who is a candidate for a cochlear implant needs imaging for us to be able to work that up. What we want to see on imaging is we want to be able to evaluate the inner ear, in particular the cochlea. We want to make sure that it's not ossified. We want to make sure that there's a place where a cochlear electrode can go, because, if with some of the significant cochlear malformations, you have very different outcomes with those. And so it's a part of a consult also for the prognosis of how you're going to do over the long term with the cochlear implant. And it may have to give us some very good indications of areas of risk. Are you more likely to have a CSF leak when we open into a cochlea that has an incomplete partition? We're not going to be able to preserve your hearing if you have an enlarged vestibular aqueduct or sac along with it. So absolutely essential in the process of cochlear implant. So genetic hearing loss is a huge subject. And like I said, I know that I'm glossing over a lot of it. I mean, in particular, autosomal recessive non-syndromic hearing loss is the most common genetic hearing loss that we see, and that's connexin 26 or gap junction. And that's something that we wouldn't necessarily do imaging on those kids unless it's within the light of working them up for a cochlear implant. So syndromic hearing impairment has other things going involved. Now, the other thing I should say in our ENT world about all the genetics with hearing loss is that if we identify a baby at newborn hearing screening who has a hearing loss, all of those kids are being referred for a genetic workup at this point. And most of the time it's a simple blood test, although sometimes it's a cheek swab. And we are literally screening thousands of these different genes that are associated with syndromic and non-syndromic hearing loss. So we used to kind of do these testing for families if they were interested, but now we're really recommending that everybody get this workup along with a referral to pediatric ophthalmology for an evaluation. So sometimes, when we're making this diagnosis, it's also with the being informed by our medical genetics colleagues as well as the genetic testing. So one key syndromic autosomal recessive is Pendred syndrome, which is associated with a euthyroid goiter and sensorineural hearing impairment. This is related to the Pendred syndrome gene, which is referred to as SLC26A4. This is telling you partly where that name comes from, but the PDS gene itself codes for the Pendred protein that's an anion transporter. So the hearing impairment in Pendred syndrome is variable in terms of severity as well as age of onset and severity and variable in its prognosis. Some patients have a profound loss from birth, and sometimes there's later onset of sensorineural hearing impairment. But the imaging studies show cochlear hypoplasias in concert with enlarged vestibular aqueduct. So here's a picture of the transmembrane anionic transporter for the PDS. And there's some interesting evidence of genetic heterogeneity, but with families with full Pendred phenotype, there's actually little heterogeneity. The enlarged vestibular aqueduct can occur independent of Pendred syndrome and is extremely important for us with diagnosing hearing loss and kind of helping prognosticate what's going to go on with that. This is just kind of showing on the this illustration here, the vestibular aqueduct is going into the otic capsule here and is associated with the enlarged endolymphatic sac. And this is the abnormal, and here's kind of the typical normal. The typical hearing loss patterns are either flat or downsloping, and they can be either sensorineural hearing loss or a mixed hearing loss. It's a common cause of a low-frequency conductive hearing loss also, but we don't really understand where that comes from. Progression of hearing loss is seen in at least 25% of patients with enlarged vestibular aqueducts, and associations of hearing changes have been associated with head trauma, but that remains controversial. Sorry, my lights went off. I wasn't moving enough. So another non-syndromic autosomal recessive, very important type of hearing loss is Usher syndrome, which is characterized by both hearing impairment and a visual impairment that's caused by retinitis pigmentosa. So roughly half of the people in the U.S. that are deaf and blind have some form of Usher syndrome. It's been clinically recognized for over a century, although its molecular cause was identified in the last 20 years, and it's genetically very heterogeneous. What we see here on the right of the screen, this is a normal examination of the eye and the retina, and here is the retinitis pigmentosa, the changes associated with Usher syndrome that cause the vision loss, and this is why a major reason why every child with a hearing loss, even with genetic testing, also gets an evaluation of their pediatric ophthalmology evaluation. So there are three main types of Usher syndrome that we see. Type 1 is a congenital profound hearing loss with absent vestibular function, and their type 2 is moderate hearing loss and normal vestibular function. Type 3 then is progressive hearing loss with variable degrees of vestibular dysfunction. The hearing loss, can either respond depending on the level in type 2 to hearing aids, but sometimes necessitates cochlear implant. So autosomal dominant syndromic hearing impairments now. So one of the major players in this is branchio-otorenal syndrome, which is eponymously known as Melnick-Fraser syndrome. But this is characterized by multiple anomalies of different pharyngeal arch-driven structures, deriven structures, renal anomalies, and hearing impairment. And this has been reported to affect as many as 2% in children in schools for the deaf. The hearing loss can be conductive. That can be due to abnormalities of the auricle, the external canal, or the ossicles. And you can also see inner ear and mixed hearing losses that can be due to a spectrum of cochlear hypoplasias and dysplasias. So here's an example of a kid who you can even see there's a more normal appearing pinna on this left side and this cup ear deformity with an oral atresia on this right side. So there's a lot of variability that can be seen here. As many as 40% of these kids would demonstrate cochlear abnormalities. The external air defects can include ear pits, skin tags, and other appendages. And then in addition to the hearing, there are cervical cysts and sinuses due to these various pharyngeal cleft anomalies similarly present in a highly variable fashion, as well as renal anomalies. But because of the severity of renal manifestations, this is an indication for providing some type of renal evaluation for all these children who present with hearing loss and ear abnormalities and these branchial cleft lesions. It's associated with mutations of the EYA gene, and this has been evolutionarily identified also as far back as in the Drosophila as the eyeless gene, but it's a very interesting transcription factor that's regulating gene expression through key times of embryogenesis, and that's probably involved with the morphologic changes in the ear, the branchial structures, and the kidney. There's a ton of heterogeneity in this, though, because only about 15% of people with branchiotorenal syndrome show EYA1 mutations. And so that may have something to do with needing more precise and rigorous criteria for the clinical diagnostics of branchiotorenal syndrome. And in more narrowly defined populations, up to 40% can be found that carry the EYA1 mutations. So otosclerosis is poorly understood, the gene associated with it, but we always should be discussing it, because if you have a normal exam in a kid who has conductive hearing loss in one or both ears, that may be otosclerosis. We tend to see that in older kids. The peak incidence is ages 15 to 45, but the genetics are complicated with the incomplete penetrance. If you have a couple or a person who has otosclerosis, one of the parents, the chance of having a child with otosclerosis is 1 in 4. And you can see bilaterally symmetric progressive conductive hearing loss in patients affected with otosclerosis, but 10% have sensorineural hearing loss as well. And this is showing a mid-medullary section of an inner ear with this surrounding the inner ear, this otospongiotic plaque that is associated with the sensorineural hearing loss. Osteogenesis imperfecta also can present with conductive hearing losses. The traditional diagnostic associations are bone fragility, blue sclera, and hearing impairment. It infrequently occurs, but it's a mutation in COL1A1 or COL1A2. That's a type 1 collagen effect. Get hypermobile joints, short stature, more triangular face, cardiovascular abnormalities, and skin disorders, although, of course, there's plenty of variability here. Neurofibromatosis type 1 and type 2 can cause hearing loss, much more variable in NF1, a little older in NF2. Imaging is obviously key for both neurofibromatosis type 1 and 2, but usually that is MRI that we're doing for that. So I'm glossing over that a little more for this presentation. Stickler syndrome can present with both sensorineural or a mixed hearing loss. There's hypermobility and enlargements of joints associated with early onset arthritis. There's visual changes, severe nearsightedness, cataracts, Robin sequence-like facial dysmorphology, and occasionally some spondoepithelial dysplasia. Hearing losses in about 80% of individuals with Stickler syndrome, and about 15% overall show progressive hearing impairment over time. 3 of these different types have been identified and are probably due to genetic heterogeneity with variable expressivity. Treacher-Collins is another important hearing loss related syndrome in our clinic. It's also known as mandibulofacial dysostosis, and there can be abnormalities of the jaw, face, and ears with, again, significant variability in phenotype. Bilateral microtias and oral atresias are common with individuals that show either total pure conductive hearing losses or mixed hearing losses with inner ear malformations. About 30% of kids with Treacher-Collins will demonstrate some type of vesicular abnormality that will contribute to a conductive hearing loss. The sensory neural component can vary from mild to severe. And that may be associated with a degree of inner ear dysplasia, which again, we can only figure out with imaging. You can also have defects of the vestibular apparatus. One of the characteristic features is the hypoplastic zygoma that results in the downward palpebral fissures that are characteristics of Treacher-Collins, and bilateral colobomas of the upper eyelid and symmetric but hypoplastic mandible are also commonly observed. Many of the individuals with Treacher-Collins demonstrate mutations in the TCOF1 gene, which is normally expressed during early craniofacial development. Inheritance is typically autosomal dominant, but you can have new mutations of TCOF1 in as many as 60% of affected individuals. Waardenburg syndromes are hearing impairments with a white forelock, heterochromatic irides, dystopia canthorum, and synaphrese. This highlights a phenomenon of the variable expressivity of hereditary disorders, and only about 20 to 30% of individuals affected by Waardenburg syndrome will demonstrate a white forelock, as seen here in this child, and the age and appearance of a white forelock is quite variable. And commonly people, who may be a little bit older may actually dye their hair, so you won't even see that when they present in clinic. So sometimes you have to ask. There are four main types of Waardenburg syndrome that are distinguished, like Waardenburg type syndrome 1 is different from Waardenburg syndrome 2 by the presence of dystopia canthorum. Sensory neural hearing loss is in 20% of Waardenburg 1 patients. Waardenburg 3 and 4 are far less common. There's also Klein-Waardenburg syndrome, which has bony malformations of the hands and forearms, in addition to the abnormalities seen in type 1 Waardenburg syndrome. And Waardenburg-Shaw syndrome is an apparent association with Hirschsprung disease. And it's either autosomal recessive or autosomal dominant matter of transmission. The genetics are obviously, since it's a lot of heterogeneity, there's different mutations reported. PAX3, MITF, EDNRB, and EDN3 mutations have been reported, but the vast majority of Waardenburg type 1 cases are associated with mutations in the PAX3 gene, which is a critical regulatory gene in controlling morphogenesis of the face and of the inner ear. There are sex-linked disorders of hearing, pretty uncommon, 1 to 2% of cases. Up to 5% of non-syndromic profound sensory hearing loss in males can be attributed to sex-linked disorders, but no genes on the Y chromosome have been implicated as causing any hearing impairment when mutated. One thing that's important for conductive hearing losses is the X-linked gusher, which you may have a preoperative CT scan that shows abnormal enlargement of the IAC and an absence of a partition between the IAC and cochlea. This is important if someone were to do a surgery and open into the stapes foot plate, you get a CSF leak, and you tend to obviously have a very poor hearing outcome. So this warrants a more conservative non-surgical management of that types of hearing loss. Hemifacial microsomia is also another variable presentation. It's also been known as Goldenhar syndrome, and it's a significant but asymmetric craniofacial disorder that's associated with hypoplasia of the mandible and maxilla, malar, and temporal bones. The otologic abnormalities that we see is sometimes you can see microtias and anosias and atresias with preauricular tags, and abnormalities of the vestibular chain and an abnormal facial nerve course. Again, that hearing loss can be more commonly conductive than sensory neural. Okay, well, hopefully my timing works well for you guys. I tried to not include everything possible because you just have lists and lists of things, but a lot of things that are relevant to imaging, but almost every hearing loss is relevant to imaging at some point. So
thank you so much. Yeah, it's a lot of syndrome and new names for me. Yes.
I'm frequently looking up syndromes. Trust me.
Yeah. So are you going to stay here with us until the end, or are you leaving?
I will be around for at least the next half hour unless my case starts sooner than I intend.
Sure.
Yeah.
Yes. Any questions from the audience from now?
I have a question.
Oh, go ahead. Go ahead, Rupa.
Oh, hi, Dr. Yates. This is Rupa Radhakrishnan, and I'm one of the peds neuroradiologists.
Yeah.
So one of the questions I have is regarding the management when you get a report of either a hypoplastic or absent cochlear nerve. Would you still consider this patient a candidate for cochlear implantation? I've heard variably that sometimes the cochlear nerves may travel along the vestibular or other cranial nerves.
Yes, I would. It's not an absolute contraindication, but at the very minimum, it's an extremely important discussion about the variability of outcome in that situation. So one thing that would depend always on, like if there was an ABR that had some type of response, even if it was small, I would be more likely to pursue, because we have electrical evidence of the presence of a brainstem response. The other thing, or I would be more likely to pursue, and that would also be the only option. There was, and the family's desire to go to a auditory only route. But at the same time, important discussion with the family that we could do a surgery on their child and have it be just entirely no response. And so I'll definitely make it clear that I'm not aggressive about that situation, but it's not an absolute. So some kids who've had some result, but it's often not very good as well.
Thank you so much. That was a very informative lecture, and obviously it's hard to cover the entire topic in an hour. But it was amazing. I appreciate.
Well, thank you. I appreciate your compliment.
Yeah. Thank you, Dr. Yates. This is Brian Grainer. Great lecture. You mentioned.
Thank you, Doctor.
You're welcome. You mentioned canal wall up and canal wall down mastoidectomies. I've seen a couple canal wall reconstructions. And my question is, when is that an option? When do you choose it? Is it always an option?
Yeah, it's always an option. As long as you already have a canal wall there, it's even though there are prosthetic canal walls that we can replace, it's not a very good situation to go back and add in a canal wall and a canal wall down situation. So
Sure.
About 5 years ago, I was really enamored of this procedure because of all the reports of having much less recurrence of cholesteatoma associated with it. And then I had several recurrences of the cholesteatoma, even with the obliteration of the mastoid and a canal wall reconstruction. So because of that, I've become less engaged with doing the procedure and just kind of going back to more of the canal wall intact versus canal.
Awesome. Yeah, thanks. Is it a cosmetic reason to do that, or is it a functional reason?
No, it's functional, because the idea with the canal wall reconstruction is that one thing is, one of the limits of the intact canal wall is it's very hard to visualize anterior and medial to the facial nerve, in particular the anatomic area of the sinus tympani. And so you can leave cholesteatoma behind there in the typical intact canal wall procedures. The other the other part is then if you've obliterated that entire mastoid space, even if you have ongoing retraction from eustachian to dysfunctional migration or whatever the etiology of cholesteatoma, I mean, in theory, you've made it that there's no place for that cholesteatoma to collapse. But that's theory. I saw it kind of insinuate between bone chips a couple times. I mean, it hasn't been zero, but it takes a lot of time to, get all of that bone pate you need, and then you have to use a reciprocating saw up towards the brain, which can be daunting. And I got one CSF leak out of it. I mean, we stopped it at the time, of the surgery, but ultimately, to me, it was about the outcomes. If they weren't substantially better, I've kind of gone away. But I'll commit to the fact that I don't think it's a bad procedure. In my hands, it wasn't all.
Awesome. That's extremely helpful. Thank you.
Dr. Yates, hi, this is Isaac.
Hello.
That was a great lecture. Thank you so much for doing this. I have a quick question about enlargement of vestibular aqueduct. When I was a fellow, I was told that that's almost a automatic that you counsel the patient that do not participate in any contact sports. Is that still a thinking of now, or is that something different?
Yeah, there's a lot of controversy about those issues. There have been studies that have definitely said that there is a head trauma association, and then there have been pretty good population studies, although they're always retrospective case series that show that that the hearing loss is independent of that. So I punt at this point, which means I tell families that concern exists, but I tell them that we don't know it to be absolute and that it's your decision to participate in sports where there may be significant contact. I think there are other good reasons to not participate in those sports from a neurocognitive point of view too, but the evidence isn't definitive, and when it is something is as big a deal to some families as that, I tell them that's we don't know for sure. We know that this is a concern, but we unfortunately see plenty of kids with enlarged vestibular aqueduct who have a sudden hearing loss in that ear that is absolutely dependent of any type of head trauma.
Understood. Thank you so much.
Thank you.
We realize that you have a busy clinical day, so I really appreciate your time for joining us.
I'm honored to be here. Thank you for inviting me.
Let me share
Any more questions from the audience here right now? Trendy?
Any questions from Southeast Asia?
Not yet. Yeah, I have two questions, Dr. Yates. So one is we have CT and we have MRI. Which modality do you prefer in which setting? Or do you normally do both of them together?
Yeah, so generally for sensory neural hearing loss, I would do MRI. And now for any recurrence of potential recurrence of cholesteatoma, I would prefer MRI with restricted diffusion. With diffusion weighted imaging. For any conductive hearing loss, it is CT scan, pretty much as a rule, but then there is some crossover. There's a number of times when I'm going to get both. Sometimes if you get a CT with cholesteatoma, and a family really wants to avoid surgery, well, the only way for me to say, well, there's no cholesteatoma is then get a CT. And then I didn't even kind of talk about skull-based lesions, in a lot of skull-based lesions, especially of the petrous apex. Frankly, I'm going to get both.
I see. Yeah. And my second question is this is something that I wondering many years ago, and it's about a hearing loss in the patient with congenital CMV.
Yeah.
Yeah. So I mean, most of the time for the congenital CMV that has hearing loss, I believe that the structure when we do MRI and CT, it looks relatively normal. So I read from like some literature is maybe related to like some toxin or something that attack the nerve itself, so that why it cannot function very well. So my question is like, is it going to be recovered over time, or do we need to do anything on those aspects?
If it's someone with congenital CMV that has no other finding than hearing loss, there is some suggestive data, and we were involved with a trial here that actually treated with a antiviral to see if that prevented hearing loss and prevented the sequelae of the congenital CMV. When there's other findings on MRI that that there's so much variability.
Yeah, like brain defects. Yep. Mm-hmm.
Yeah, but what we saw on that trial is I don't think they've released the final answer, but statistically we just didn't get convincing results that intervention worked that way. The other part of that is that in that population without any other findings, there's a lot of variability as we follow those kids over time, how much further hearing loss they have. So basically, I'm not answering your question because we don't know.
No, but I think that's help. Yeah. But I mean, like normally it's just like the toxin attack the nerve, right? It's not like the anatomical.
Yeah, it's not anatomic. Yeah, it's either the toxin or the virus itself attacking the nerve.
Mm-hmm. Mm-hmm. Thank you so much. Yep. Thank you so much for your great lectures and teach us many clinical aspects.
Thanks for the invitation.
Yes. Mm-hmm.
So let me share my slides. Let me see here. Can you see? Oh, move the screen onto the side. Can you see my?
Yes.
Yes.
We
Okay.
can.
All right. Great. So let's go and get started. So thanks so much again for Dr. Yates for that the clinical correlate and all the clinical aspects. So I think as a radiologist, it's always important for us to. I feel like sometimes we are describing finding in a vacuum. So I always encourage residents to do a lot of clinical contacts, look at the notes, especially when it comes to ENT studies. So good morning, everyone, and good evening in Southeast Asia. My name is Isaac Wu. I'm a neuroradiologist here at Indiana University. So I'm just going to follow up with Dr. Yates' lecture about imaging aspect of the congenital hearing. But the purpose, I realize that most of the audience, or the majority audience we have, are trainees. So I'm actually going to use this opportunity just sort of going through CT of the temporal bone, or mostly CT of the temporal bone, and how you approach those step by step. This is always one of the things that's more intimidating for me, at least when I was a trainee. CT temporal bone is always intimidating because there's so many different components compared to brain. So let's just get started. Dr. Ye talked great definition and different aspect about congenital hearing loss, conductive hearing loss, sensory neural hearing loss, and sometimes you can mix. I think since to remember as a radiologist is that you can different literature, different statistics, but I think majority that will tell you that it's not majority of the patient coming that you will see abnormality. A large percentage does have abnormality on CT or MRI, but not majority. So I remember talking to a trainee who was a little bit frustrated. It seems like the couple small sample case that he see on a particular rotation pediatric neuroradiology that he feel the hearing loss, the case comes in was normal or negative. But you have to remember that majority or a slight majority, you won't see anything. But as Dr. Yates described that the things that we are very important to look for are the things that clinician cannot see. So the inner ear part, that's the our job as radiologists. And I think this is a surprise to nobody that more severe symptom is the diagnostic EO, of course, is going to be higher. And also the diagnostic EO is going to be higher when the findings or the symptoms unilateral compared to bilateral. And of course, also depend on the referral basis. If the case comes from ENT or ENT colleagues from Dr. Yates, those studies tend to be more positive as opposed to sometimes more general practitioner. So just remember that. And in other words, a lot of things as of now, radiology was still not very good at scanning the membranous portion or the microscopic level, like hair cells. So a lot of, even though patients may have relatively profound symptoms, but in imaging at least is negative, both on CT and MR. That's because if you look at this example 3T, really we cannot see an inner ear structure all that well, as much as we pretend we can see it, but it's still quite blurry. But things may be changing, right? Because that 70 is coming. So now you can see the inner ear structure much better than before. So those days are coming. And I went to radiology thinking that I can avoid histology, but I think that become inevitable that we need to relearn histology again. I just want to go through, again, going to radiology, I thought I can avoid embryology. I didn't realize I'm going to end up doing a lot of pediatric. So that's also inevitable. As far as the ear development goes, remember the model that we have different pharyngeal arches and between your pharyngeal cliff or branchial cliffs. And if you look at this cartoon, so 3D cartoon on FOSS, on the side, you can have the future development of the eyes and future development of the ear, or the different plateaus. And if you take a section across and kind of looking at the axial view in this sort of simplified cartoon, you can see different layer development from ectoderm, that's in blue, and mesoderm, that's in the sort of the pink color, and then endoderm is going to be yellow. And different part of the ear, inner ear, outer ear, are coming from different component. So for example, when you look at the pharyngeal cliff and then pharyngeal pouch, that the future otic plateau is evaginated from the ectoderm. And contrast that to some other portion of the inner ear structure or the ear structure, such as the different type of nerve, for example, is coming from a separate component of the germ cell layers. The future ossicles are coming from, for example, mesoderm instead of from the ectoderm. And then also you will see that there's a invagination and evagination of the endoderm as well as the ectoderm that will form the future ear canal. Just a kind of enlarged view. As you go further development, again, the ossicles are coming from the mesoderm, whereas the inner ear structures are coming from the ectoderm. And the interesting thing about it is that in the inner part, the tympanic cavity, as well as pharyngotympanic tube, are come from the endoderm. I think what I find interesting is that the tympanic membrane actually comprises of all three cell layers, or three germ cell layers. Right, outer part you have ectoderm, and there's a small sliver of mesoderm that's sandwiched between the endoderm. So I find that development interesting. But what's the point of all this for us radiologists? The point is that think about the development, they'll come from different parts. So therefore, for example, if you see a external ear and the middle ear anomaly, they often go hand in hand, go together. Whereas when you see external middle ear anomaly, it's not as common as you think that you're going to see inner ear structure. Again, for example, the other day we see somebody with EAC atresia and some of the middle ear structure anomaly, and the resident was surprised to find that the inner ear structure was completely normal. So perhaps that should not be a surprise that they are coming from different aspects. So again, I like to use this as an opportunity really just to talk about more anatomy and the approach of CT temporal bone for the trainees in the audience about how you approach CT temporal bone. That's one of the more, for me at least as a trainee, is one more intimidating portion of the neuroradiology. So let's just kind of go through, and then I will show you some of the pathology example that Dr. Yates mentioned related to inner ear, or excuse me, the congenital ear malformation, hearing loss. I'd like to start with the example that I actually see as a fellow 5 years ago. Just kidding. That's a long time ago. As a fellow, a long time ago. I'm getting old. So this is a patient. This is a 7-year-old girl. Comes in with a history we're giving was bleeding, and hearing loss and bleeding. What they didn't tell us at that time was a patient had a procedure in the office, and the bleeding occurred after the ear tube was placed. And you can see on this axial CT, axial and the coronal. On the right side, you can see there's a lot of abnormal soft tissue opacification, and compare that to the normal left side where it's aerated. This one right here is just a von averaging, is not some kind of blockage, but this one right here is abnormal in the osseous portion of the EAC. And I think some of you already guessed what happened to this patient. We'll come back to this case, and just to highlight the importance to describe the anatomy and some of the anatomical variant, because that sometimes can lead to outcome that's quite dire, like in that case. So back to how you do CT temporal bone for the trainees. The approach that I think everybody does, we all do things just a little bit differently, but it's almost universally, we kind of approach the temporal bone. My recommendations are focus on one side at a time and try not to jump back and forth unless they're completely normal. Otherwise, you're going to confuse the yourself, you're going to confuse the reader. So focus on one side at a time, just focus on right side or focus on the left side. And then break them into main 3 components, which is outer ear, inner ear, and the, outer ear, middle ear, and the inner ear. And then don't forget to everything else. As a radiologist, you are responsible for everything else that you see on the imaging, including sinuses, vasculature, of course, the portion of the brain and brainstem that you can see. So start with the outer ear portion. I think this part is something that for me is the often the structure here, the clinician can actually see that much better than we can. So it's something that as far as radiology goes is probably not as probably the least important, I would say. But just think about the general component. Think about the ear, think about the external auditory canal, and the boundary between the outer ear and middle ear, of course, is your tympanic membrane. Again, many of the structure that the clinician can see this better than I can. So I heavily rely on their clinical finding. And then I put mastoid right here. It just said it's just right there. I inspect it, not that it's part of the outer ear per se. So you always want to compare from axial or standard axial view and the coronal view, and in sort of correspond to the Netter diagram. So you just look at the collagenous portion of the EAC and the osseous portion of the EAC. And often we see this non-specific opacification that just turn out to be cerumen. But certainly if you see bony erosion, you want to make sure you mention that and raise a concern that this may not be as simple as just a earwax, for example. And the structure that, as far as boundary goes, the landmark, you can look at this sharp point, the superior attachment of the tympanic membrane, that's scutum. And you can see tympanic membrane barely on a normal CT. If you see it too thick and too well, that's probably abnormally thickened. And just to draw in there, I'll say slightly cave in just a little bit. And on the small top portion, again, that's not something that we can see as a radiologist, but certainly clinician can see that very well. It's a small portion that's pars flaccida, and the majority is going to be pars tensa. And here is the picture I borrowed from internet that you can see that for us, we cannot distinguish between different parts on CT or on MR, but certainly otoscope, we can see the different parts. So pars flaccida is just a smaller triangular portion on the top. So Dr. Yates shows a great example about different type of the potential outer ear malformation from different severity. Again, I think that's probably not a surprise to any radiologist that the severity of the ear can also usually correlate to severity of the external and the middle ear malformation. And that has to do with essentially failure of canalization of the first pharyngeal cliff. There are different spectrum, of course, could be complete atresia, so there's no tympanic plate. essentially just complete blockage, versus you can have stenosis to the external auditory canal. And also, of course, that would affect the development of surrounding structures, right? And often, even the structure is relatively normal, they will be displaced from the normal position. So that's always a tricky part to try to figure out where the structures are. And those, of course, some of them has very important surgical implications, such as if there's anomalous cause of cranial nerve 7, it's important to mention, and that way that give people heads up that it may not be in the typical location as we expect. And obviously, you don't want to damage the nerve when you're doing your procedure. And this is just one of the example of a EAC atresia. You can see there's a small pit that we can see imaging. Of course, they can see much better than we can. Clinicians can see that much better than we can as radiologists. And also to mention that the aberrant course of the facial nerve, etc. And there are different part of the, you can talk about different component of the structure that's abnormal. And I found in some of the review article, they can talk about different scale. And I don't particularly report the different points and different scale, but I do look at all the structure, just make sure that at least they look normal, enlarged, too small, too large, etc. So some of the checklists, and it's no different than the thing that we routinely inspect step by step as far as the structure that we're looking at when we do our CT temporal bone. But just sort of it's nice to have a sort of checklist to make sure that you inspect all this individual component that may be relevant for the future surgery or reconstruction. So, for example, the size of middle ear cavity. So obviously the middle ear cavity, the larger the volume is more conducive to surgery as well as the reconstruction and the accessibility, etc. So for example, this patient down here has a much better middle ear volume compared to this example up in above. So also that's sort of the outer ear part. So for me as a radiologist, the outer ear component is not as is a part that clinician can see much better than I can. So I tend to focus a little bit more on the next two components, which is middle ear and the inner ear. So move on to the middle ear portion. The boundary between outer ear and middle ear is the tympanic membrane. Again, on CT, usually you're not going to see all that well. If you see too well, it may be abnormally thickened. So the structure that you inspect as a boundary is that first inspect the scutum, which is the sharp point, the superior attachment of the tympanic membrane. And the top portion, pars flaccida, and in the lower portion, the majority is going to be pars tensa. And that can translate, that anatomy also translate into another pathology that Dr. Yates talk about greatly, and then I'm going to cover a little bit. That's going to be cluster teratoma. But just generically, a major component that you want to check, you want to look at different compartment, which is epitympanum, mesotympanum, hypotympanum. Look at scutum, look at this place called Prusac space, or lateral epitympanic recess, and then we'll look at the ossicles individually. So the compartment that you can look at them, we can break them into three parts. That's epitympanum or the attic, mesotympanum, and hypotympanum. And really, they are more arbitrarily divided space. So how do you find epitympanum or the boundary? So if you look at the tip of the scutum and then look at the tympanic facial nerve canal, and you draw a line across. So above that, that's going to be your epitympanum or attic. Notice that there is a connection from the epitympanum or passage into the middle ear cavity, into the mastoid air cell. So that's added as an entrance. So there's a direct connection from epitympanum into the mastoid entrance. And then if you draw a line roughly parallel to the floor of the external auditory canal, so the vast middle part is going to be mesotympanum, and hypotympanum is going to be much smaller, just smaller portion. Here's the Netter diagram. Although the eustachian tube is not strictly in the hypotympanum, as the drawing suggests. And that's in the anterior part, it's called prototympanum. So other structure that you can inspect very well on the coronal view, you can see tegmen tympani, which is the roof of the tympanic cavity, and then this important structure called cochlear promontory. So you see this bulbous curve that's formed by the basal term of the cochlea. And this is also an important structure to inspect, because some of the classic pathology likes to go to that particular location. The Prusak space, so we talk about scutum. Adjacent to that, you have a small space that's sandwiched between the scutum and the adjacent ossicle. That's the Prusak space. Or if you don't like the epinums, the place, the whole thing is referred to as lateral epitympanic recess. And the tegmen tympani is sort of the covering of the tympanic cavity. So if certainly you want to mention if there's a dehiscence, or worse, if sometimes you can actually see encephalocele that's coming from the dehiscence of the tegmen tympani. And the cochlear promontory is that bulbous area, bony area. So those are the structures that you can inspect extremely well on a well-done CT, especially on the coronal view. And then the ossicles. Ossicle, as I think we all learned in medical school, that comprise of three main components. So here, if you blow up from StatDX, nice drawing from StatDX, you can see malleus, you can see ingus, and you can see stapes. So see, everybody remember that that's the conductive components of the hearing. And if you look at individual components, you can see many of this on CT as well, is that you have a process that's where the umbel is, and then you have a manubrium, of the handle of the malleus, and you have lateral processes, and the neck of the malleus, and the head of the malleus, which look like ice cream on the CT temporal bone, as I will show you in a little bit. Here you can see some of the components that our clinician colleague can see very, very well. And here you can see the umbel, this small portion right there, and the handle that's going across. And here you can see the lateral process that's sitting on the tympanic membrane and other component. And for the ingus, there are different parts. So you have a short process going across this way, and you have the body, and then you have a long process that's going up and down, or superior inferior. And the articulation between ingus and the stapes, that's a lenticular process. You can actually see that part also well, or fairly well on CT. Then you can see stapes. And there's a neck of the stapes, and you have the anterior and posterior crura, as well as the foot plate. And remember, the foot plate is flush against the oval window. And the job of the ossicle, as everybody remember, you have a sound transmission, you have mechanic amplification of the ossicles that in turn would put pressure or vibrate the oval window, and that will send the transmission of the fluid or perilymph, and that will spiral across the cochlea and essentially come back down and decompress out the round window. So those are the structure that you can all see, we can see on CT and quite well. So here's another netogram for the relationship between the foot plate, and then here kind of extending down from the oval window, and the transmit the pressure across through the perilymph, and then eventually the pressure decompress out of the round window. So oval window is on the top, round window is on the bottom. Now on the imaging, especially on the axial view, imagine that you have an axial view that's coming across this structure, the head of malleus and the short process of the ingus. And that view looks exactly like ice cream on the axial view. So you see that quite well. So for example, when you go through the axial view, coming down from superior to inferior, the thing that I will inspect, you're going to see ice cream on ice cream cone So that's the head of malleus, and the cone itself, ice cream cone, is the short process of the ingus right here. So that configuration is important. You want to make sure the ice cream stay on ice cream cone. You want to make sure that the ice cream is not melted into the ice cream cone, and you want to make sure that ice cream is not falling off the ice cream cone. So that's a nice configuration. And then you will follow that by two dots on the axial view, and that represent the neck of the malleus as well as the ingus. And then you see two dash. The posterior dash that now you're looking at notice that you can actually see the lenticular process right here. So you're looking across the posterior dash is the junction between the ingus as well as the stabi. So from the top, I see ice cream and ice cream cone. I see two dots, then I see two dash. And you can see a crura right here and the foot plate that extending into the oval window, which is a little bit not as easy to see on the axial view compared to the coronal view. So that's a general configuration that you want to look at for the ossicle and the structure across. And on the coronal view, the general configuration that you will see is that you can actually see an umbel right here. And again, tympanic membranes is a little bit harder to see. You can see the head of the malleus. And here you can come down here, you can see part of the ingus, and the ingus would take a sharp 90-degree turn, just like in this picture from StatDX. And because you're looking at this way straight down, it would present usually as just one straight line, the stapes, and now extending into this divot. And that divot is going to be an oval window. And some of the relationship that we'll talk about again is that notice that little dot that's adjacent to the just right outside the oval window, not inside the oval window. That is a tympanic portion of the facial nerve canal. And remember, if you draw a line between the scutum and the facial nerve, that defines the epitympanum. And this relationship between where the facial nerve is relative to oval window is also very important to mention. Once in a while, you come across a barren course, which the facial window is buried way deep inside the oval window. Assume the facial nerve is buried inside the oval window, and you really want to draw attention to that, because if a surgery was to perform, and that has an increased risk for potential facial nerve injury. So that's, again, general configuration of where the ossicle should look like. Oval window is a divot. And the rung window is, remember, oval window is superior, rung window is inferior, right? If you find the basal term of the cochlea, you will see another divot as if there's an airfield space right here. That's the rung window. So oval window on the top, rung window at the bottom. And this is an example of this is a teenager comes in with a conductive hearing loss. When you compare to right side, the normal side, obviously left side looks very abnormal. The entire middle ear cavity is opacified, and this opacification surrounding the ossicles all the way around. And also appreciate that the ossicle appeared to be more demineralized compared to the normal right side. So this is the cluster teratoma. Dr. Yates mentioned that it's very important for you for us to read the MRI in this case, because the classic finding for cluster teratoma is the sign of restricted diffusion. So in this case, you can see there's a two type of diffusion restriction. So one of them, the one that you are more familiar with for the trainees, you are more familiar with the diffusion weighted sequences are standard EPI diffusion. And those are the ones that you use on the standard brain MRI to look for acute stroke, for example. The problem with EPI sequences is that they are extremely prone to susceptibility artifact, including air. So you are trying to image a structure that's filled with air in the mastoid air cell in the middle ear cavity. Naturally, you are going to be obscure in mostly, if not completely. So EPI diffusion would not work too well when you try to look for middle ear structure. So therefore, whenever you have suspicion of cluster teratoma, make sure that you protocol it or talk to the tech if they don't usually scan middle ear stuff. Make sure that they're also including haze diffusion or non-EPI diffusion. which, as you can see, the same patient, you can see the size of the cholesteatoma shows diffusion restriction is much more pronounced compared to this one that you can barely see. So make sure that you have proper type of diffusion weighted sequence. And here there are a couple of classic findings that make this more like cholesteatoma on CT, or at least your index of suspicion should be higher. Is that notice that the scutum, the important structure to inspect, is blunted, and the Prusak space is completely filled and expanded compared to the normal right side. And those are a couple of the classic findings related to on CT of cholesteatoma. And this is acquired form. So just quickly, again, just sort of to reiterate what Dr. Yates already talked about, is that when you think about acquired cholesteatoma, if you think about the scutum, the reason why we inspect scutum and Prusak space is that scutum is a superior attachment for the tympanic membrane. That's also where the pars flaccida is. And adjacent to the pars, or above the pars flaccida, or adjacent to scutum, that's where the Prusak space is. And that's why we sort of talk about that. And some of you come across the CT bone template, dictation template. Those specific components also mentioned for this reason. So let's just comb in a little bit. Let's say you have a chronic inflammation and you have essential blockage of eustachian tube. So you have this chronic negative pressure that causes scarring at the tympanic membrane. When you have negative pressure, guess which part tend to be break? Which one is more flaccid? Is it the pars flaccida or pars tensa? So you can imagine that with the negative pressure, now you develop this retraction of the pocket at the pars flaccida. So this area is going to start to accumulate the keratin debris. And as Dr. Yates talked about, keratin debris could be quite inflammatory. Also, it's a great culture medium for various bacteria. So they tend to expand and start to erode to the adjacent structure. Therefore, the first place that they tend to erode is going to be scutum, the attachment point. So one of the earliest signs, or one of the classic signs on CT, is going to be blunting of the scutum. And also is right adjacent to the Prusak space. So naturally, the place that they want to go first is going to be in Prusak space. And eventually, they can go everywhere, basically. And because they are very inflammatory and also causes recurrent infection, they tend to be erosive to different bony structure. So therefore, they can erode through the tibia tympani. They can certainly erode the ossicle, as well as erode through the lateral semicircular canal, for example, and worse, and extending into destruction of various inner ear structure. So it can be quite nasty. And this is one of the nice diagram from STAR-DX. I have a real life example that look almost just like the cartoon drawing, right? So again, blunting of the scutum, expansion of the Prusak space, various erosion of the bony structure. In this case, you can see erosion of the ossicle, almost erosion through the tibia tympani, erosion through the lateral semicircular canal, kind of like this diagram here. And on the otoscope, you will see a scarring of the pars flaccida, the tympanic membrane, and the pathology itself, it tend to be pearly white, as opposed to other structure that have different color. So look for erosion of different bony structures. And so those are the things that you want to pay attention to. And also important anatomy is this cochlear promontory. That's formed by the basal term of the cochlea. The reason that's important is that, especially for board exam, for those who are studying for upcoming board exam, one of the potential questions they can ask you is that they show you a lesion that is reside in this region by cochlear promontory. So the couple of differential diagnoses that you can think about, especially two, is either going to be a cholesteatoma, but in this case, it will be congenital, not acquired, congenital cholesteatoma versus paraganglioma or glomus tumor. And so this is an example of a child comes in with a conductive hearing loss. And here you can see on the right side, the normal side, cochlear promontory. On the left side, you can see right around the region of cochlear promontory, you have this quite a bit of large lesion, right? It's bulging into the tympanic membrane. Again, cochlear promontory, just for your reference, on the normal side. So we think about those two main lesions, right? So paraganglioma versus congenital cluster teratoma. And on otoscope, that they look different, but sometimes when it's small, they may not see as well. So on imaging, this turns out to be a congenital cluster teratoma. And on CT, it's very difficult to tell them apart. Even sometimes when you give contrast, you would think that the paraganglioma will light up on CT. It does, but it's not as easy to see as you think, but MRI is much better. It can occur anywhere, but that's a classic location. But certainly that's the one that they will show on board exam if they will show you one. And for the purpose of radiology, though, when you study, just consider congenital cluster teratoma is essentially the same as epidermoid cyst. So if you think about that, then if you just have to remember what epidermoid cysts look like, and you will look identical, right? So that means that you'll be bright on T2. That means that you should not enhance centrally. You may have a thin peripheral enhancement for epidermoid cyst or congenital cluster teratoma. And then they also will have restricted diffusion for epidermoid cyst and congenital cluster teratoma. On the other hand, glomus tumor, a vascular tumor, a paraganglioma, it would enhance. You enhance quite avidly centrally. So just for the purpose, also when you study for board exam, just think about congenital cluster teratoma equals epidermoid cyst. That way you just have to study for one entity. And what they look different is that from this article, you can see the difference between congenital cluster teratoma is the cluster teratoma tend to be described as pearly white, whereas glomus tumor or paraganglioma is an angry red. It's a vascular tumor. So they look quite different also. I'll contrast that to the acquired. So remember, acquired start off with scarring at the pars flaccida and the retraction pocket. For the congenital cluster teratoma, the tympanic cavity is, tympanic membrane is intact. So acquired, you can clearly see a scarring consistent with prior inflammation. We talk about quite a bit about the difference between canal wall up and canal wall down, so just not going to repeat that. But just for you, when you're looking at image, the simple way just look at it. Just look at the posterior wall of the external auditory canal or the anterior wall of the mastoid. If it's still up, that's canal wall up, and if it's taken down, that's canal wall down. So when you see history of mastoidectomy, you can just talk about there's a prior history of canal wall down mastoidectomy, canal wall up mastoidectomy. Pop quiz, right? What's the smallest bone in human? It's going to be stapes. So the ossicles, there are various anomalies that you can see, and there are different. I can't get through all of them. But certainly I have not seen all of them either. They can be anywhere between complete absence, which I actually have never seen except on the literature. And often you see hypoplasia or fusion of various parts, either with themselves or to the adjacent bony structures. And remember, this often associated with external ear anomaly. The middle ear anomaly comes together. So when you see EAC atresia, for example, it's not surprised that you will find various ossicular malformation. So some of the checklists that you can do, just inspect them, make sure that you can see their joint very well. This is a child comes in with a external auditory canal atresia. And here you can see there's a, this one is very dysplastic. On the left side also looks a little bit dysplastic, but on the right side, it's much more hypoplastic, dysplastic. The joint between the hypoplastic head of the malleus and the ingus, remember they should look like ice cream cone. And this one looked like just the melted version of a tiny ice cream, I guess. And also note that the short process of ingus is fused around the adjacent bony structure as well. So do look for the different scalar anomaly. So lastly, after you finish your inspection of middle ear, then you turn your focus to the inner ear part. So inner ear, right? The things that you should routinely inspect minimally is going to be the course of the facial nerve, and look at the structure of inner ear, a particular main component, which is going to be cochlea, vestibule, and semicircular canal, and look at the size of the vestibular aqueduct. That's very important, especially for congenital hearing loss. And on MR, and this is where the often MRI is the modality in kids that we will go to for sensory neural hearing loss for inner ear structures. And if you remember the trajectory of the facial nerve, let's look at facial nerve first. It is coming from the facial nucleus, and that's kind of wrapped around and extending in the anterior part of the internal auditory canal. And you go anterior into the genicular ganglion anteriorly, and you will take a bending. So that's an anterior genude bending of the knee. And then you come sort of horizontal across the tympanic cavity. So you have tympanic segment. And then on the posterior part, they do another dive. So they will extend, now they of course become superior to inferior. So that becomes the mastoid segment of the facial nerve. And you can see that quite well on CT, not the nerve itself, you need MRI for that, but you can see the facial canal. So for example, you just have to hallucinate. Obviously you won't be able to see the brainstem all that well, or in fact, not at all. You just have to kind of hallucinate the course of the facial nerve going across the anterior portion. Then you will see the facial nerve canal going across, right? The small, very tiny, so you have the sternal portion, a very tiny labyrinthine segment extending into this bending anterior genude and the genicular ganglion right here. So notice that now you become a sort of horizontal course across a tympanic cavity. That's your tympanic segment. So you can try to follow the course going across into genicular ganglia, take the anterior bending, so that's an anterior genude, and coming across. And the thing that to remember, let me get rid of the line here for a second. Things that to remember, you can always reliably, in a normal course, you can find it underneath the lateral semicircular canal. So when you're lost, just find your lateral semicircular canal that's easy to find and look underneath it. You will see the tympanic segment of the facial nerve. And on the coronal view, you can find the, look for the cochlea, and some people call this Gary the snail sign. The cochlea look like a snail on the coronal view, spiral, and you can see the eyes of the snail, or Gary the snail. That's a facial nerve coming away and toward you. When the eyes cross, that's going to be the anterior genude and extending into genicular ganglia. So look for that. And remember, the tympanic segments also always reliably traversing underneath the lateral semicircular canal. So look for that and look underneath it. That's where you'll find it. And eventually it takes a posterior genude and then become a straight shot superior to inferior through the mastoid segment and on the coronal view. So you can always follow that. And also know the relationship between the facial nerve and the oval window. Make sure that they are staying outside the oval window. So the thing that you inspect, and this is something that you can see much better on MR, is going to be, remember that you have bony labyrinth on this diagram. You have the spiral cochlea, look like a snail. And vestibule is sort of the adjacent bulbous dilatation that contains or connected to 3 semicircular canal, superior, posterior, and the lateral semicircular canal. So that's a bony housing of the inner ear structure, right? Then here you can see oval window and round window on the bottom. Housing within is your membranous labyrinth, the things that we can see on MRI. And again, you can see the different semicircular canals. And then you can see the cochlear nerve on MR, and as well as vestibular nerve and some of the subcomponents of the ventricles. So look for those individual components. And again, just for the function, optical amplify the period length, transmit pressure from oval window across the cochlea, decompress out of the round window. And that remind me of a St. Patrick well in Orvieto, in Italy. It's kind of interesting because you can actually walk all the way down to the well. The stairway is big enough for a donkey to walk all the way, carry a heavy water bucket. And the engineering construction is such that the people who are going down will never meet the people who are coming up. So it's spiral case that way. That way make it very efficient, does not create a traffic jam, right? So you have a spiral down to the well and then spiral back up, so they never meet each other. That's kind of like remind me of cochlea, right? You have the period length that's kind of extending into the scalene vestibuli and then spiral up to the cochlea and then come back down and decompress out of the round window. And the thing that you can see that really well on CT, you can see the cochlea. And the individual cochlea component you want to look for is that you want to make sure you see this nice bony box inside. That's modiolus. That's where the cochlear nerve kind of extending into it. And you want to make sure that the bony septum is intact. That's the interscalar septum. And those are the structure that you want to inspect, make sure they are intact. And then make sure that the cochlea consists of normal 2.5 turn. And on the coronal view, cochlea look like a snail. Then we talk about the facial nerve. And then you can see the semicircular canal, especially lateral and superior semicircular canal, very well. Make sure that they are not dehiscent, especially the superior semicircular canal. And the vestibule, on the axial view, you should see this bulbous dilatation of the vestibule, and you can see the posterior semicircular canal very well right here. Lateral semicircular canal, superior semicircular canal, make sure that they are normal in size and properly formed. Same thing on the coronal view. And the mnemonic, I think many of you heard about, is the 7-up coke down. And I also like to add the VA on the back shelf. So that mnemonic is means that if you look at the internal auditory canal en face this way, look down the barrel, the 7 facial nerve, 7-up, is in the superior anterior cochlear nerve is going to be in the anterior inferior portion of this internal auditory canal looking en face. And then the vestibular, the superior VA, 8th cranial nerve, vestibular division, VA, superior inferior division. So it's kind of a nice mnemonic to remember that. For congenital hearing loss that we tend to look for inner ear anomaly stuff, you should inspect the internal cochlea. Remember 2.5 turn. So this is nice, nice view, 1, 2, and the apical turn. That's what you want to look for. You want to look for the modiolus and the interscalar septum. You want to make sure that each component are relatively well seen. And you want to make sure that the lateral semicircular canal, which is the last one to fully form, that they are preserved. And usually when they are fully formed, the other two should be okay, but not always. You can have, that's not always the case, just generalization. And the important thing to look for the vestibular aqueduct. So inspect all those components for your congenital inner ear malformation. If those major components is fine, chances are you won't miss something big. And then look at the internal auditory canal, the size, and at the same time look at the opening of the cochlear nerve. Remember, cochlear nerve extending into the modiolus. Make sure the cochlear aperture is nice and wide. It's not stenotic. Because if you see a very stenotic cochlear aperture or a completely blocked cochlear aperture, there's a good chance that the cochlear nerve is also abnormal. In that case, you want to look for MRI to make sure that you can see cochlear nerve that's intact. This is a nice example of a congenital anomaly where you can see modiolus is really not very well defined at all. So the modiolus deficiency, interscalar septum is not well seen. The turn, the apical turn is not very well formed at all. There's a large vestibular aqueduct right here. So that's a classic case of incomplete partition type 2, the more common one. I'm going to skip this for the, I know that we are short time. So I'm just going to show you some of the example of the inner ear malformation that we can see. And this is where the MRI comes in. That's going to be more handy when it comes to inspection of this anomalies. So we can really think of they develop. So for example, a most extreme form is during early development or third trimester, that where you have nothing entry vestibule and semicircular canal, but no cochlea. Then the next one is that you have something that look like a cochlea, but all the cavity are essentially just formed as one large cavity. That's the common cavity malformation. And the next one is going to be, since I'll start to form, but the inside, the partition cochlea is essentially nil. So that's the incomplete partition type 1. Then you can have cochlear hypoplasia, and the most common one is the one that we're going to focus on, is the incomplete partition type 2. So the aplasia. So that one is in some ways probably easier to look for because it's completely absent. Again, I don't have a good example here in our system. So this is from AJNR. So just sort of demonstrate that this one right here, you have some structure that's formed on the right side, but on the left side is completely absent. I think things that they talk about also is that once in a while you'll come across a very, very severe labyrinthitis ossificans where everything is ossified and wiped out. So how can you tell that that is not, patient does not have an aplasia or labyrinthine aplasia, maybe things that never formed rather than normally formed and completely ossified? You want to look for presence of the cochlear promontory. So in this case, this is a very severe case of labyrinthitis ossificans. Everything's ossified, but the promontory is there. We'll compare that to labyrinthine aplasia, that's completely absent. So that one you're probably not going to come across, if ever, other than on the textbook. But the next one, cochlear aplasia, and this is an example that we have on the left side. The right side is also abnormal, but on the left side, notice that you can see facial nerve, but I don't see any cochlea. Remember, cochlea is more interior, the vestibule is more posterior. Here you can see a vestibule that is bulbous and dilated, and the individual semicircular canal is not formed at all. So this is an example where the cochlea is not there at all. So this is more severe cases of the next category. The next one is also more common, but it's not that common, 25%, but you will see during your rotation, possibly, is common cavity, which means that you cannot really separate the component between the cochlea and the vestibule. They just present with essentially one large cavity. Contrast that to this side, you can see cochlea, vestibule, semicircular canal. On this side, you can see the internal auditory canal extending into what anteriorly should be a cochlea, posterior vestibule, but everything just sort of blending as one large cavity. So that's the common cavity malformation. Incomplete partition type 1, and this is one that's more severe. And here you can see, I just blow it up for easier to see, is that you can see rudimentary cochlea, but you see really not a lot of the individual turn. Also, importantly, the inside structures such as modiolus, interscalary substance, essentially not developed. Often you also accompanied by a malformed vestibule, and some people describe that as a figure of 8 malformation. So just look for the inside. So the inside partition is essentially not formed. So incomplete partition type 1, that's more severe. The vestibular aqueduct is typically not enlarged with this one, unlike with the more common type 2 malformation. So this is an example of incomplete partition type 1. Again, you see cochlea just start to form as a one blob. Inside partition, really you don't see any formation of the modiolus or interscalary substance, etc. And the vestibule has that kind of a dilatation figure of 8 pattern. But the one that you are, cochlear hyperplasia is the one that you may or may not come across. This right here you can see on the left side. Here you have a small cochlear bud, if you will, but the vestibule here is relatively formed. Vestibule lateral semicircular canal is small, but the posterior semicircular canal, superior semicircular canal appear to be intact, but the cochlea is tiny. So this is an example of cochlear hypoplasia, but the one that you'll probably come across is the most common type, that's incomplete partition type 2. That is the one that historically some people just name that Mondini malformation. I think that's a term that we probably try to avoid because it causes a lot of confusion. Also because it's the most commonly encountered inner ear malformation. I think that's why we start to call everything Mondini malformation. So to try not to talk about Mondini malformation unless it's absolutely classic. Which means that not only you're going to see the incomplete partition of the cochlear structure, but you also should have a enlargement of the vestibular aqueduct. So incomplete partition type 2, here is a nice example of that. On this side right here, you can see the cochlea is better formed than the type 1, but instead of 2.5 turn, I can see 1 kind of a, basal turn, second turn, but the apical turn is not well formed. And also you can see the modiolus, you can see sort of a bony structure, but it's not very well defined. And the interstellar substance is also not very well seen. So you have a modiolar deficiency. So the inside partition cochlea is essentially incomplete. And often you will see also is the enlargement of vestibular aqueduct. How do I know that's too big? You compare that to the adjacent posterior semicircular canal. If the caliber is bigger than the posterior semicircular canal, that's too big. There are measurements that you can do, but I think most of it is just eyeball and make sure that the size is not greater than the adjacent posterior semicircular canal. So those are the ones that you will come across the most likely when you deal with inner ear malformation. And there's actually a type 3. So we talk about, Dr. Yates talked about this, the X-linked Gaucher, but for the sake of time, we're going to skip that. Sometimes, again, pay attention to the individual semicircular canal, and sometimes you come at dehiscence of the superior semicircular canal like this. But make sure that they have nice bony covering. Other stuff to look for, remember the lateral semicircular canal is the last one to form. So do inspect. Of course, look at all the semicircular canal, but sometimes often the one that you see abnormal is a lateral semicircular canal. In this case, you can see the posterior semicircular canal actually looks pretty relatively well formed. The adjacent vestibular aqueduct, that's not enlarged compared to that. And then you can also see in this case, there's a superior semicircular canal, but the lateral semicircular canal just look like a blob, a continuation of the vestibule. And the central bone island, let me see on the other side, you can see the central bone island. This one's also malformed, but at least the central bone island is there. This one's completely absent. so that you can sort of look at it again. You can measure if you want, but usually we just inspect rather than do the measurement. And you can also see that on MR. So in this case, for example, you can see that the bone island is tiny, bone island is absent. So look for lateral semicircular canal anomaly. And the vestibular aqueduct, just to reiterate, is roughly parallel to the posterior semicircular canal. If it's bigger than the posterior semicircular canal, it's probably too big. And it is the most congenital, #1 most common imaging finding for congenital sensory neural hearing loss. Very, very common board exam question, by the way. And I think we talked about earlier, as Dr. Yates was talking about that, you used to thought that this is something that you really want to avoid contact sport, but so there's sort of I guess opinion is not uniform as far as whether or not you really, the trauma truly accentuate the degree of hearing loss when you see enlargement of vestibular aqueduct. On MRI, instead of seeing the bony structure, you see dilatation of the T2. It's filled with fluid, right? Let's facial nerve. Let's just skip that one. And everything else, look at for the sake of time, I'm going to just kind of fast forward through this. And the things I want to highlight is the vessel. You want to make sure the vessel is not aberrant, especially the carotid artery and the adjacent jugular vein, because you want to make sure that it's not dehiscent, it's not high writing. Otherwise, if you did not pay attention to the aberrant course of carotid artery, you will come across with the initial case I start with, that pretty unfortunate case when I was a fellow, that patient has a eardrum, ear tube placement in the office. And unfortunately, it was unknown to everyone that patient has a aberrant course of internal carotid artery, and that was injured during the fairly routine office procedure, and they cannot stop the bleeding. So of course, they did. My job as a fellow that they did a CTA, and then they proved that you can see a little bit. I don't know if you can see a little bit of outpouching right here. That's the site of injury, and they have to do emergency embolization. So they essentially sacrifice the internal carotid artery, aberrant internal carotid artery. And one of my co-fellows, whose fiance is actually an ENT resident in this particular case, and she take a picture, you can actually see the coil that's poking through the tympanic cavity or tympanic membrane. You can see that. Luckily, though, the kid has a very nice collateral from the other side, so the patient actually did not stroke out on the right side of the MCA. The MCA is completely supplied through the left side, so it's fortunate for that case. So be careful. When you see something that's red, don't touch it. At least don't touch it before you confirm. That's about it for, I'm just going to skip the summary again, just the same thing that we go over. So sorry, running a little bit over. Any questions?
Thank you so much, Dr. Wu. Always excellent lectures on the temporal bone.
There's a lot to go through. I know it's a little bit daunting, especially when you first started, but just kind of keep that systematic way going, and then you should be fine.
Yeah. I have questions, Dr. Wu.
Sure.
So I mean, like normally for the CT temporal bone, we do axial, coronal, and sagittal, but there are also some special view, like a Stegler or portrait. Do you think it's like that useful or not? Do we need to do that things routinely, or like what is like your checklist on those special views?
And I think at least for pediatric, we don't do that routinely, right? I know that for adult, and I do not do adult head and neck, just for disclosure, is that as a fellow, when I was trained, that they do routinely do Purcell view and the standard view, which is just sort of the oblique view, want to see the full extent of the it's the inner ear structure, the semicircular canal. I think the cases that they show me, I think is useful. But do I rely on those views? Because we don't do that at Riley. So my answer would be, for me, is no, just because we don't use it. But maybe once we start using it, we'll find that helpful. But nowadays, it's easy with all the 3D reconstruction. We can just recon it if we want on our own. So not like in the older days where you have to scan the patient again in different view. So I think that's could be easily done if we think it's helpful.
Hey, this is Drew. Yeah, I think that we pretty much really only do those in the setting if you're concerned about superior semicircular canal dehiscence. You really get a good look to make sure. Sometimes it's really difficult to tell if there's just thinning versus dehiscence. So I think that's really the main use of those views. And I agree with you, Isaac. The few cases on the ped side, I just use the NPR tool and make my own obliques on the fly and do that. I think usually on the ped side, it's usually an incidental finding if there's some thinning. I don't think that's usually symptomatic in that regard.
Thank you so much, Drew. Because right now I saw that maybe like IU North trying to send those like a spatial view to the system. Okay. So I'm not sure is it the new protocol, or also some Riley cases that they start sending those things. So I'm not sure that it's like a new protocol or something, or any special that we should look for. But I mean, normally I just use axial and coronal, like the standard one.
Right.
Yeah, I don't I don't know that there's a new protocol to do them. And one of the reasons I think that we may not really need it is because we're getting much more thinner slices and higher resolution now than we were before. So we can identify a lot of these dehiscences and other anomalies just on our routine 3-plane imaging. But again, I'm not speaking for the adult side since I don't do adult head and neck too. And we have the ability to do the 3D reformats on packs when we need them.
Yeah, 100%.
Any questions from the trainee here? Okay, so if not, thank you so much. Go ahead. If not, thank you so much, everyone, for joining us today. Thank you, Dr. Yates and Dr. Wu, for giving us really comprehensive reviews on the pediatric hearing loss, clinical aspect, and also imaging findings. So I send you guys an evaluation in the chat box. So please complete those things so we know that what we can do better for next time. And for the people in Thailand, so we sending you an evaluation form, and please complete those evaluation form by this weekend, and you will get the Thai CME credit. And thank you so much, everyone, for joining us today. Thank you, and see you next time. Bye.
Thanks for having me here. Bye-bye.
Bye-bye. Thank you.